All right, today we're going to talk about bile duct pathologies. This is a really high yield topic, so we'll talk about a lot of different diseases, hopefully in a pretty short period of time. I've got some very nice tables that we'll go through. You can screenshot them, do whatever you need to do with them. Um, Bile duct pathologies show up on every exam. They're very popular in the hospital too, so you'll see them all the time. So we're going to discuss bile duct anatomy, cholestatic pattern of liver injury. We'll talk briefly how gallstones form, and then we'll get into the meat and potatoes, right? We'll talk about biliary colic, acute cholecystitis, choledocholithiasis, acute cholangitis, gallstone pancreatitis, cholangiocarcinoma, PBC, and PSC, and then we'll put it all together in a final question. So this was the case I posed on Instagram. It got some very interesting results. I didn't think the case would be that difficult, but I had answers kind of all over the place. So this would definitely be a good lecture for people to watch because no one or the right answer actually was not the most commonly picked option. So we have a 56-year-old woman presents to the ED with 18 hours of right upper quadrant pain. She has nausea and low-grade fever. The pain started after a large fatty meal and has been persistent since onset. She has no prior history of gallstones or liver disease. On exam, she has right upper quadrant tenderness with a positive Murphy sign. No scleral icterus is noted. Lab studies show a white blood cell count of 14.2, an AST of 42, ALT of 48, an ALP of 102, a GGT of 34, and a total bili of 0.8. The abdominal ultrasound is pending, and I'm asking you, where is the obstruction? Is it in the common bile duct? Is it in the intrahepatic bile ducts? Is it in the cystic duct? Or is it in the ampulla evader, right? So pause this and consider, and then we'll move on. So in this patient, the obstruction will likely be in the cystic duct, right? This is likely acute cholecystitis. So we have the classic symptoms. We have the fever, and we have the right upper quadrant pain following the fatty meal with the leukocytosis and the positive Murphy sign, right? That's classic acute cholecystitis. The absence of jaundice and the only mild non-obstructive elevations in the transaminases and the alkaline phosphatase with a normal total bilirubin really argue against obstruction of the common bile duct, the intrahepatic ducts, or the ampulla evader. Okay. Really, I'm gonna delve into this more when we get to there. But when I think about acute cholecystitis, we have blockage of the cystic duct, which causes inflammation. Bile gets shot out from the gallbladder, but it gets stuck. It refluxes back. It causes irritation and makes my gallbladder really angry, and then potentially it could get infected too. That's why we get fever. That's why we get an elevated white blood cell count, and that's why we get Murphy's sign. And we're going to talk all about this more as the lecture progresses. The thing, though, is with my liver, the bile ducts that come from my liver are still going to be patent. And I'm going to show you a beautiful picture on the next page. And because they're patent, bile is still able to flow from the liver. And we're not going to see too much of an hepatocellular injury. And the bile ducts within the liver and outside of the liver, other than the cystic duct, are totally fine and patent. So we really won't get any reflux of bile acid into the liver that would cause like an elevated ALP, a GGT, an elevated ALT, and AST. So what I'm getting at here is in acute cholecystitis, the labs are typically normal, or we're just going to see very slightly elevated ALT, AST, ALP, and GGT. And in our case, right, the AST was just barely above, the ALT just barely above, the ALP normal, and the GGT normal, and the total bili totally normal. That's why it's pointing me towards the cystic duct. And again, we're going to break this down more because I need to show you the anatomy. I need to show you the pathophase, and then we'll recircle back to this question, and everything will make even more sense. So an anatomical review, this should hopefully be really helpful for you guys. Anatomic structures, we have the gallbladder, which stores and concentrates bile. Remember, bile is made in the liver, stored in the gallbladder where it gets concentrated. We have this beautiful cystic duct here. The gallbladder shoots out bile, right? CCK gets made whenever we eat fatty meals. It stimulates the gallbladder to contract. We push the bile through the cystic duct, right? And then it's going to meet up in the common bile duct. So the liver is shooting out bile from the right hepatic duct and the left hepatic duct. They come down and they meet in the common hepatic duct. And then the common hepatic duct, when it meets the cystic duct, forms the common bile duct. That common bile duct then moves down, and when it meets the major pancreatic duct, that's called the ampulla evader. And the ampulla evader is regulated by the sphincter of Oddi. So again, liver makes the gallbladder or makes the bile. It gets stored in the gallbladder. When we eat a fatty meal, CCK gets made. It stimulates the gallbladder to contract. Some of the bile is flowing from the right hepatic duct, from the left hepatic duct. When those meet, that makes the common hepatic duct. The common hepatic duct, when it meets the cystic duct coming straight from the gallbladder, forms a common bile duct. When the common bile duct meets the major pancreatic duct, that forms the ampulla of Vater, which is regulated by the sphincter of Oddi. I just also mentioned the cystic artery is a branch off the right hepatic artery, which supplies the gallbladder. Okay, that's kind of an important. That's more of like a step one concept. I was also asked that on my like acute surgery rotation. So it's an important one to know. Um, so when I think about my cholestatic pattern of liver injury, right? The definition, right? This is an impaired bile flow. It's going to be an accumulation of the bile components into the blood. Okay. So my classic lab findings are going to be an elevated ALP, an elevated GGT, mild or minimally elevated transaminases, so my AST and ALT, plus or minus hyperbilirubinemia, okay, depending on how bad the severity is, right? So the pathophysiology, this will help us like wrap our mind around things. We get obstruction or dysfunction in the bile ducts, either the intrahepatic bile ducts, like my right and left hepatic bile ducts, or the extrahepatic bile ducts, say my common bile duct, or even potentially my common hepatic duct when it's left the liver. Um, so these some of that obstruction leads to the retained bile salts and bilirubin, which will reflux out. So let's say we had damage right here. We had some sort of blockage in the common bile duct, okay? So a lot of you guys answered common bile duct. If I had obstruction here, my gallbladder is shooting out bile, my liver is shooting out bile through the common hepatic duct, and it's going to get stuck here and it's going to reflux back. It's going to reflux back into the gallbladder and into the liver. When it refluxes back into the liver, right, we're going to cause hepatocellular fibrosis and injury, and my liver cells are going to get really angry and they're going to release all their ALT and AST. We're also going to cause damage to the bile ducts themselves from all this reflux and all this fibrosis. And the bile duct epithelium cells that get injured are going to release ALP and GGT, right? So that the same thing can happen if we had damage or blockage to the ampulla of Vater. We're now just a little bit deeper. But now there's an obstruction here, right? The bile is flowing down, but it's got nowhere to go, right? And it's going to back up into the gallbladder, into the liver, and into the pancreas, right? So we could see that cholestatic pattern of liver injury. So we could see possibly an elevated ALT and AST, an elevated ALP and GGT, possibly an elevated bilirubin if the liver damage is bad enough that we either can't conjugate the bilirubin or we're still able to conjugate the bilirubin, but it's got nowhere to go. Okay. And now that there's blockage of the ampulla of Vater, the bile can actually reflux, or the bile itself probably won't reflux, potentially, but we're also blocking the pancreatic enzymes from getting out into the small intestine. And so those can back up and also damage the pancreas itself, right? That is the pathophysiology of acute pancreatitis, is we have some sort of overactivation of trypsinogen into trypsin. Trypsin stimulates the whole activation of the rest of my pancreatic enzymes, and they chew up the pancreas. It's overactivation of them. And in this case, we're blocking the outflow of these pancreatic enzymes so they'll feed back and be active and eat up the pancreas. Some of that bile can reflux too, which could cause damage. So when I see the elevated ALP, that reflects injury to the bile duct epithelium, but we'll talk about why ALP itself is not super specific. The GGT confirms that hepatic origin. So common causes would be gallstones like the choledocholithiasis and cholangitis that I kind of briefly have mentioned. Malignancy, so if we have pancreatic head cancer, right? So if I had a cancer right around here that was obstructing the ampulla of Vater, the bile can't flow through and it will reflux back. If I had cholangiocarcinoma, which is a tumor of the bile ducts itself, if I had primary biliary cholangitis or primary sclerosing cholangitis, which a lot of you answered intrahepatic bile duct obstruction, which you were probably thinking PBC. And I wrote that question to try to get people to think about PBC because I made the patient the right age. If I were to have intrahepatic bile duct obstruction, so let's say we have obstruction here, 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 whatever, we're injuring the liver itself, right? We're injuring the bile duct themselves. which can then cause the bile to reflux and then injure the liver. So we could potentially get elevated ALT and AST, but we're causing massive damage to these bile ducts themselves. So the epithelium is going to get damaged and we're going to release ALP and GGT. If we go back to our case, right, the ALP and GGT were totally normal. That's because in our case, the obstruction was somewhere right here, and it's just backing up and causing inflammation in the gallbladder itself, not the whole rest of my bile duct system. Okay, so hopefully that's starting to make sense. Some certain drugs like anabolic steroids and chlorpromazine can also cause it. So again, our clinical correlation to our case, the ALP was normal or as high normal, right, early on in acute cholecystitis. The GGT was normal. The ALT and AST were just mildly elevated. That suggests early gallbladder inflammation, acute cholecystitis. It's not yet obstructive. So again, here, there's obstruction in the cystic duct. The gallbladder can't empty, but the liver can totally empty. There's not an obstruction in the common bile duct or at the ampulla of Vater or anything inside the intrahepatic bile ducts. So there's no reflux of bile back into the liver. When there's no reflux of bile back into the liver enzymes really aren't going to get super duper high. The ALP and AST or the ALP and GGT also aren't going to get super duper high because there's no cholestatic pattern, right? There's no cholestasis that's refluxing back, causing fibrosis of these bile duct epithelium and leading to the release of ALP and GGT. So I'm hoping that that's starting to make sense. If it's not, hopefully we'll continue to flesh it out, and then please email me, and I'm happy to meet on Zoom and make it make sense further because this is a very important topic. So we'll keep fleshing it out, right? ALP, alkaline phosphatase, it is made from the bile duct epithelium. That's the most relevant for a liver disease. But the bone, right? Osteoblast activity, growing kids, bone disease, and metastases can also have elevated ALP. The placenta and the intestine also make ALP. So ALP on its own does not tell me it's a bile duct problem, okay? Isolated ALP could be hepatic, it could be non-hepatic, right? So that's a classic like step one question. The patient has elevated ALT or ALP. What do we want to do next? We want to get a GGT. And the GGT is primarily biliary epithelium, okay? Small amounts elsewhere, but not really important. So if I see an elevated ALP and GGT, I can be pretty certain it's a biliary or a hepatobiliary cause, right? It's the bile duct epithelium, maybe intrahepatic, maybe extrahepatic, maybe both that are caught that have this problem. If it's ALP and just GGT, then it could be bone or it could be other non-hepatic causes, right? Because if the ALP is elevated but not the GGT, I'm pretty certain this is not a biliary duct problem because a GGT would have to be elevated. So then we look elsewhere, right? Where else is ALP made? Well, it's made in the bone. Maybe it's made in the placenta, right? If it's a pregnant woman, maybe it's made in the intestine, right? Classically, it's going to be bone for like clinically relevant diseases. All right, let's keep it moving. So gallstone pathophys, right? So how do gallstones come to form? There's a couple different mechanisms. We have supersaturation of the bile. So excess cholesterol or bilirubin exceed the solubility and they form a nice little crystal and then will be insoluble. That can lead to a gallstone. Gallbladder stasis, if the gallbladder isn't emptying as properly or contracting as properly, it allows crystals to grow and aggregate. There are different nucleation factors like mucins and proteins that promote the stone formation. When we have reduced bile acids and phospholipids, there's less things to solubilize the actual bile itself, and that favors the cholesterol to precipitate and leading to a stone formation. And then certain infections. So the bacteria beta-glucuronidase can convert the conjugated bilirubin to unconjugated, and then that can lead to the formation of black, brown, or pigment stones. So again, supersaturation of the bile, stasis, certain nucleation factors that favor the formation of stones, reduced bile acids and phospholipids leading to less solubility, and then certain infections via the beta-glucuronidase leading to the formation of unconjugated bilirubin and black and brown pigment stones. So major gallstone types, this is classic step one land. Cholesterol stones will be yellow-green. They are the most common, especially in like Western, so in the United States. Pathophysiology, again, supersaturation of cholesterol plus decreased bile acids and phospholipids, so less solubility, and plus gallbladder stasis, all are going to favor the formation of gallbladder or cholesterol gallstones. We think about our female fat, fertile 40, rapid weight loss, OCPs, pregnancy, and dyslipidemia. Look for those in your practice questions. Look for those in your patients in real life. Black pigment stones are classically made of calcium bilirubinate. They're radio-opaque. We see this in chronic hemolysis, which leads to an increased production of unconjugated bilirubin, which precipitates with calcium and then can form these black pigmented stones. Remember, in chronic hemolysis, when my red blood cells get sheared and they hemolyze, we release LDH, we release heme, we release indirect bilirubin, right? That heme is going to bind up with haptoglobin, so my haptoglobins are really low. So when I think about hemolytic anemia, I think about high LDH, low haptoglobin, elevated indirect bilirubin. So we can see this in hemolysis of any kind. I did a whole lecture on MAHA, and I'll do a whole lecture on hemolytic anemia at some point soon. So sickle cell hereditary spherocytosis. We can also see it in cirrhosis too. Brown pigment stones are soft and infectious. Again, it's the bacterial or the parasitic infection leads to elevated beta-glucuronidase activity, which leads to the unconjugated bilirubin. That unconjugated bilirubin can then go on and form supersaturate and then form these stones. So certain biliary infections like E. coli, Ascariscus, and Clonorhynchus. All right. So now that we've covered a lot of the groundwork, let's get into the meat and potatoes, the actual diseases. So I've set it up for history and presentation, pathophysiology, labs, next best step in management, and then USMLE tips. So how is biliary colic going to present? It's going to be postprandial right upper quadrant or epigastric pain. It's triggered by fatty meals. The pain is classically less than 6 hours. That's even being generous. Like most times the pain won't last longer than like 3-4 hours. Nausea, bloating, early satiety, no fever, jaundice, or systemic symptoms, and Murphy's sign is negative. We'll talk about Murphy's sign in a second. The pathophys, we get transient cystic duct obstruction by the gallstone. The gallbladder contracts. The stone temporarily blocks the duct, and there's no inflammation or infection. So again, if we go back to our picture, there's a stone blocking here. The gallbladder contracts. It will be blocked, and it will reflux back, but the stone's only temporarily there, and then it falls back in, or it falls back. So it either falls back in this way or it falls back in this way down the common bile duct, and it's small enough that it's not going to cause a problem. This differs from acute cholecystitis because the stone gets actually stuck here for an extended period of time. So the gallbladder is constantly contracting. The bile is constantly refluxing and constantly causing the inflammation. In biliary colic, it's more of a transient process, right? That's why the pain usually only lasts for a short little bit because the stone will move and that will relieve the patient's pain. So the labs are typically normal because one, we're only blocking the cystic duct for a short period of time. So we're not going to get the reflux of bile back into the pancreas. The pancreas isn't going to have the enzymes eating up itself, and we're not going to get this cholestatic pattern back to the liver either. Okay. So labs are typically stone cold normal. The white blood cell count is normal. Maybe if the patient has some sort of like big pain response, maybe the white blood cell count might be slightly elevated. But next best step, this goes for like literally every patient with right upper quadrant pain. First off, I'm going to say this. I'll cover this in my localized abdominal pain lecture that I'm hoping to do pretty soon. Whenever you see a patient with like upper abdominal pain, whether it be the right upper quadrant, epigastrum, or left upper quadrant, that right there is enough to make me think about getting an EKG. And I absolutely will get an EKG on that patient because sometimes when I do my chest pain lecture, I'll talk about it too. MI can show up really weird. And when I think about pain up at the top of my abdomen, it's close enough to my mediastinum and my sternal like point that I need to think about some sort of acute coronary syndrome. If I don't get an EKG and I miss an MI, man, like that's extremely bad, right? So any upper abdominal pain is usually good, like indication enough to get an EKG, rule out the ACS, and then we think further. I'll also tell you for any female of reproductive age, we should get a beta HCG. We should get a pregnancy test, right? You're like, the right upper quadrant, like that's not where I would expect for like an ectopic pregnancy or something like that. You know, things get weird in pregnancy, right? It's a quick and easy test. We need to rule it out. We need to rule out pregnancy. I also need to rule out pregnancy because some of the tests we might want to do in some of these biliary diseases, like if I wanted to do say like an MRCP or some of these more like invasive tests, we might not want to do things like that if the patient is pregnant, right? The classic example is like we don't really want to do a CT scan in a patient who's pregnant because that will give radiation to the fetus, which isn't what we want to do, right? So again, any patient with like upper abdominal pain, probably get an EKG. That might not be presented on a USMLE, but for the rest of your life, think about it. Any patient of who is a female with a reproductive age, we should think about actually we should get a beta HCG. Rule it out. Um, so the next best step, really, after we consider those things, right? The next best step in every single bile duct or right upper quadrant pain, we should always get a ultrasound first. That's always the first line. So if you're reading a USMLE question and the patient has right upper quadrant pain, they can give you a whole nice, beautiful vignette. If they haven't said anything about getting an ultrasound, boom, that's the easiest question I could ever be asked. Get in a right upper quadrant ultrasound. It's very quick and it's very sensitive for a lot of these diseases. Um, if the patient continues to have constant biliary colic, we could do elective laparoscopic cholecystectomy, okay, if they're having these symptoms. Dietary modification, if they're not a good surgical candidate, right, reduce the fatty foods. So again, USMLE tips, look for a right upper quadrant pain after a fatty meal. Again, the fatty meal stimulates CCK. CCK will cause the gallbladder to contract, which gets stuck against a stone for just a short period of time until the stone falls one way or the other. The labs are normal. We differentiate this from cholecystitis because in cholecystitis, the gallstone is stuck there for a long period of time. So we see consistent pain, we see consistent fever from the long-term inflammation and Murphy sign, which we'll talk about in a second. We're usually not going to need a HIDA scan. I'll talk about a HIDA scan in a second. All right, acute cholecystitis, right? So this was our case. So history, we usually see right upper quadrant or even epigastric pain because sometimes it can radiate to the epigastrium. And this is going to be for longer than 6 hours. It often starts after a fatty meal. We usually see some sort of nausea, vomiting, anorexia. And again, in this sense, like anorexia doesn't mean the patient's super skinny. In this sense, anorexia means the patient doesn't want to eat. We will probably see some sort of systemic signs like fevers, chills. They will have this positive Murphy sign, and I go into Murphy sign on the next slide, so I'll leave it at that. Murphy sign is a really good indication of acute cholecystitis. And then they may have referred pain to the right shoulder. That's because my phrenic nerve sits right around my right upper quadrant, and my phrenic nerve actually will come back to the same spinal, the dorsal column of the same spinal nerve, like root that my shoulder nerves come to. So like I have shoulder nerves that like when I touch my shoulder up here, it's sending signals back down to the dorsal column of my spinal cord at X area. Okay. The phrenic nerve of my diaphragm also moves back to the same dorsal column root of X area, right? And so my body is way more used to having like pain on my shoulder than maybe pain of my phrenic nerve or my diaphragm. So when those signals come back and they cross or they link up at the same spinal cord and it goes back up to my brain interprets it more likely as it's a shoulder pain than it is actually like diaphragmatic or phrenic nerve injury. Okay, that's kind of the working theory of how referred pain works. So the pathophysiology, again, we've talked about it, but it's persistent cystic duct obstruction by a gallstone. Okay, we get bile stasis, inflammation of the gallbladder wall, and then possibly a secondary infection, like classically our GI bugs, like E. coli, Klebsiella, and Enterococcus. We can end up getting ischemia and edema that can worsen the inflammation. So again, in these patients, we're going to see a mild leukocytosis. The ASP and ALT are usually mildly elevated. The ALP, GGT are usually normal or just slightly elevated. And then the bilirubin is normal, mildly elevated if the CBD is not involved, right? So if it's just a cystic duct, right, there's no reflux of bile back into the liver and into the intrahepatic bile ducts. So there's no inflammation, fibrosis, scarring of the bile ducts in the liver itself, the intrahepatic bile ducts. So there's not going to be too much of a release of ALP and GGT. We can get some because the gallbladder itself is obviously made up of the bile duct and the cystic duct is a bile duct, right? So we may get some, but we're not going to get this massive rise in ALP and GGT like we might see in choledocholitis or cholangitis. And we're not going to see a super high level of AST and ALT like we maybe might see in choledocholitis or cholangitis, where that bile is just constantly refluxing back and causing hepatocellular injury. So again, I kind of explained that on this, so I don't really need to go into all this. The bilirubin is usually normal because again, we're not having this hepatocellular injury. I think that's the only one I didn't explain. So again, next best steps, easy peasy. We do right upper quadrant ultrasound, right? Sometimes step 2 land, they can get a little tricky. You suspect acute cholecystitis because the patient has right upper quadrant pain for over 6 hours. They have fever, chills, they have this positive Murphy sign, and you're like, yeah, I'm thinking it's acute cholecystitis, but the right upper quadrant ultrasound was non-conclusive. So what do we do next? We do what's called a HIDA scan. So HIDA scan, we basically it's like a nuclear medicine scan where we're shooting a dye inside the bile ducts, and it's really, really good to tell us is the cystic duct patent or is it not, right? So it shoots a dye, and then we can do a big scan to see how that dye is moving through the bile ducts, and it's a really good test for seeing the cystic duct patency. Okay, so again, first line, right upper quadrant ultrasound. Hopefully that shows us because it's quick, easy. If it doesn't, we can go to HIDA scan. Okay, next steps, we're going to keep the patient NPO for a little bit. We're going to give them IV fluids. We'll give them IV antibiotics. And we usually want to cover gram negatives and anaerobes. So good options there would be things like piperacillin, tazobactam, ciprofloxacin, Metro is a good one too. And then we'll usually do cholecystectomy within 72 hours. So sometime during their hospitalization, we usually like to let the inflammation die down a little bit. So again, USMLE tips, persistent right upper quadrant pain, fever, Murphy sign, think acute cholecystitis. We do right upper quadrant ultrasound first. We do the HIDA scan if the ultrasound is equivocal. Early cholecystectomy is preferred once the patient stabilized, and complications of this can be gangrene, perforation, abscess, or emphysematous cholecystitis, where we get fluid kind of like around where the gallbladder was, and that can lead to, it's just like a nidus for infection. So it's like fluid and air, emphysematous around the gallbladder, just asking for infection. So Murphy sign real quick. So the core concept, we have peritoneal irritation of an inflamed gallbladder. In acute cholecystitis, we have this persistent obstruction of the cystic duct, which then bile is refluxing back into the gallbladder, causing gallbladder distension and inflammation. We get edema, we get wall thickening, and we get paracholecystotic fluid, as fluid is kind of leaking from this edematous gallbladder. The gallbladder lies right under the anterior abdominal wall near the costal margin. So when I do Murphy sign, right, I palpate deep under the right costal margin, and I ask the patient to inspire. When they inspire, the diaphragm moves down, and the inflamed gallbladder gets pushed right into my hand. This peritoneal stretch plus the inflamed gallbladder contacting my hand leads to a sudden sharp pain, and the patient's going to stop breathing, right? It's going to be such a shock to them that they'll stop breathing. So the Murphy sign is positive when I deeply palpate their right upper quadrant. I ask them to take a big, deep breath in. And if they have to stop that deep breath in at some point without doing a full deep breath, I consider that a positive Murphy sign. We can also do a sonographic Murphy sign where I literally just take my ultrasound probe, and if I place it on the right upper quadrant and it causes pain, that's a positive Murphy sign too. It's not positive in biliary colic because we have transient obstruction without ongoing inflammation. So there's no significant gallbladder wall edema and no peritoneal irritation. Really good topic to understand. Choledocholitis. So how is this going to present? We're going to see right upper quadrant or maybe even epigastric pain. It may be intermittent or persistent. It often, again, starts after the fatty meal. We get nausea and vomiting. We may or may not see the jaundice, the dark urine, the pale stool, and the pruritus. So in this case, this is all due to the fact that my bile and my bilirubin can't get into the intestine. So when it refluxes back, right, I have an increased amount in my bilirubin in my system. So that can lead to jaundice, okay? The dark urine is because now we're not having bilirubin that gets absorbed via the intestine and makes its way to the kidney. And it usually gives our urine a certain color. And so now we have increased amount of abnormal bilirubin that is floating through the system and can lead to a darker urine. The pale stools is because we're not reabsorbing that bilirubin. And so that bilirubin, it gives our stool some of its color. So now we get pale stools. And the pruritus occurs due to an increased bilirubin that is known to cause itchiness. Okay, that mechanism's a little more, they're not fully sure why. There's usually no fever in choledocholitis unless cholangitis develops, and the Murphy sign will probably be absent unless you really have big reflux back into the gallbladder itself, but the Murphy sign is usually absent. The pathophysiology, the gallstone obstructs the CBD, the bile can't drain, so there we get reflux, intrahepatic bile duct dilation and bile backup. And if prolonged, we can have risk of ascending infection, cholangitis, or pancreatitis. The gallstone that's sitting in my common bile duct is just acting like a nidus for bacteria to latch on and move upward or infect the stone itself. Okay, so the labs will usually see AST and ALT that are moderately elevated, or they may be very high early, right? We're getting the reflux and we're causing massive hepatocellular damage. The ALP is elevated, the GGT is elevated, the total bilirubin is elevated. The white blood cell might be normal, or if it becomes complicated, we get an infection, it can become elevated. So labs, I kind of explained all that, but you can read that on your own. The next best step in management, again, always right upper quadrant ultrasound. We'll look for the CBD dilation. If I see my CBD is dilated, that tells me there's probably a stone in there. If the diagnosis is unclear, but we're like, hey, the ALT, AST are really elevated, the ALP and GGT are really elevated, I think there's a stone in the common bile duct. We can do what's called an MRCP, which is basically an MRI for the bile ducts, okay? Or we can do an ERCP. So the ERCP, really what we'll do first is we'll do the right upper quadrant ultrasound. That's negative, or we're inconclusive. We'll probably do the MRCP, and then the next step would be due to an ERCP. Most doctors aren't just going to do an ERCP if they have a suspicion. They want to see some sort of confirmation. So the ERCP, we stick a tube down their throat. It's basically an endoscopy where then we can go down to the common bile duct itself, and then it's therapeutic and diagnostic. So we can see the stone and we can remove it. Okay. So ERCP is if they ask for what's the next step in management once we have a diagnosis, we see the gallstone in the common bile duct, you would do ERCP. Okay. Remember a complication of ERCP. One, if I'm sticking a tube down someone's throat, we can get damage to the esophagus itself and we can cause esophageal rupture. Okay. It can also lead to fibrosis and we could potentially, like down the road, get esophageal stricture. The one they're classically going to test you on is the ERCP itself. We're awfully close to the pancreas. It can cause damage to the pancreas, and honestly, like any little touch to the pancreas is going to make it super angry. It's going to release all of its enzymes, and the enzymes are going to eat itself, right? Eat the pancreas itself. So we can get iatrogenic pancreatitis as a classic complication of ERCP. So USMLE tips, we're going to look for elevated ALP and GGT and bilirubin. That tells me there's a biliary obstruction, likely in the common bile duct. The ALT or AST and ALT can spike very high initially and can almost look like a hepatitis. Remember, hepatitis, acute hepatitis, we'll usually see them in the thousands. We're probably not going to get that high in choledocholithiasis. We always want to rule out cholangitis. We're going to talk about Charcot's triad next. And then ERCP is both diagnostic and therapeutic. Again, right upper quadrant ultrasound. Then we do an MRCP. Once we have our diagnosis, we do an ERCP, therapeutic, and it's diagnostic. All right. Acute cholangitis. So again, we're going to see now right upper quadrant or epigastric pain. Fever is almost always present because we've got an underlying infection. Jaundice is very common. We could see hypotension and confusion if severe. So that's Reynolds Pentam. And then Charcot's triad is right upper quadrant pain, fever, and jaundice. So ascending cholangitis, we have a stone or stricture that obstructs the CBD, leads to bile stasis and then bile reflux. That stagnant bile is just a nidus for asking for bacterial overgrowth. Classically, E. coli, Klebsiella, Enterococcus, and Bacteroides. The bacteria ascend from the duodenum, infect this bile acid, infect the bile ducts, and then can lead to systemic infection. So again, we're going to see fever, jaundice, and right upper quadrant pain. We have blockage of the CBD. So the bile refluxes, we already talked about why you get the jaundice. We could see the dark urine, the pale stools, the pruritus, okay? We'll see the fever because we've got an underlying infection. And then the right upper quadrant pain, obviously, because that's where all the inflammation is happening. We can then, so that's called Charcot's triad. We can then progress to Reynolds pentad, where we get confusion and hypotension on top of that. Now you're thinking, okay, confusion and hypotension, that's sounding like sepsis and end organ damage, right? So we're progressing into sepsis and potentially even septic shock if the patient doesn't respond to fluids, all right? So labs, the white blood cells are elevated. The AST and ALT are elevated and can, again, like choledocholithiasis, can spike very early. The ALP and GGT are elevated. The total bilirubin is elevated and often pretty high, and the blood cultures will be positive. So again, we talked about the why, but the next best step in management, right? Obviously, we're going to diagnose via right upper quadrant ultrasound, but then we're really going to want to do IV fluids, IV broad spectrum antibiotics. I just talked about which ones. The definitive management for cholangitis is we do emergent ERCP for decompression and stone extraction. If this patient is so clinically unstable, we can't do an ERCP, we do percutaneous drainage. if we can't do that ERCP. So this differs when we have cholangitis versus choledochal. This is really important. For choledochal lithiasis, we do the right upper quadrant ultrasound, we do the MRCP, and then we dive into the ERCP. For those patients, we honestly won't even do, like most of the time, we won't do the ERCP until they're like more clinically stable. For cholangitis, we go, go, go. So for cholangitis, it's like this emergent ERCP. If we have that clinical suspicion, we do a quick right upper quadrant ultrasound. We're probably not even going to mess around with an MRCP because it's going to take too long. If we have the patient has fever, right upper quadrant pain, and jaundice, and now they're developing confusion and hypotension, we go, go, go. If they're too unstable, we're not going to do that emergent ERCP, and instead we're going to do percutaneous drainage, right? Because that's going to be, we're not going to have to stick a tube down their throat while they're unstable. All right, so hopefully that makes sense. So choledochal lithiasis, we can kind of take a little bit more time. For cholangitis, medical emergency, emergent ERCP. So USMLE tips, again, look for Charcot's triad. They're not going to tell you Charcot's triad. Fever, right upper quadrant pain, jaundice. Reynolds pentad, we're thinking about sepsis and septic shock. So think about hypotension and altered mental status. ERCP is always a definitive treatment. Delayed in the drainage will lead to high mortality. They've shown that in studies. Okay, almost done. Gallstone pancreatitis. So again, sudden severe epigastric pain rating to the back, like our classic pancreatitis. We get nausea, vomiting. Maybe we have some right upper quadrant pain. They may have jaundice if we have CBD obstruction. Usually no fever unless it becomes complicated. Again, the pathophase, we've talked about this, but the gallstone obstructs the ampulla of Vater, or it transiently blocks the pancreatic duct. The bioreflux or duct obstruction leads to premature activation of the pancreatic enzymes and the pancreatic autodigestion of the inflammation. So again, I showed you, we've already talked about it, but if we have blockage here at the ampulla of Vater, the pancreas is trying to release its enzymes. They have nowhere to go. They brush backwards. They're already activated and they're going to eat up something. And in this case, they're going to eat up the pancreas. Sometimes the bile acid can reflux too, and lead to more damage. So with this, you'll see elevated amylase and lipase, right? Lipase is a more specific enzyme that tells me it is likely pancreatitis, right? Because amylase can also come from my saliva. We'll see probably an elevated AST and ALT because the bile duct or the bile acid can reflux. So we've got the obstruction, we got the pancreatic enzymes are refluxing back, and we've got the bile acid is refluxing back to the liver and to the gallbladder. So we can see an elevated ALT and AST. The ALP and GGT and bilirubin may be elevated if that obstruction keeps occurring, and we might see mild leukocytosis. So the next best step, right, with all pancreatitis, right, obviously we're going to try to diagnose, like we probably will do some sort of imaging in this case. But really for any kind of pancreatitis, I need 2 out of the 3 things. So we're really going to look for, do they have that epigastric pain rating to the back? Do they have a lipase that's more than 3 times the normal limit? And if I have those 2, then really I don't need to do imaging. But then the gold standard imaging for pancreatitis is CT with contrast of the abdomen. So all things to consider, but really we treat pancreatitis the same. We do supportive care. We keep them MPO, we do IV fluids, and we do pain control. We try to get them eating enteral nutrition within 24 to 72 hours. That's shown better outcome. We look for complications like necrosis, pseudocysts, and ARDS. I'm going to talk more about pancreatitis in my localized abdominal lecture, and we'll talk about some of these complications. We'll do the right upper quadrant ultrasound if we have a suspicion for the gallstones, okay? If the CBD stone is suspected, we should do an MRCP or an ERCP after the patient is stabilized. Remove that stone, right? Confirm it, and then remove that stone. And then we'll usually do cholecystectomy after recovery to prevent the recurrence, right? We already know their gallbladder is making stones and it shot one out and it caused this huge problem. It's probably going to do it again. Let's take it out once the patient's stable. So again, USMLE tips, if I see pancreatitis with high levels of ALT, I want to think about gallstone pathology. It can get tricky because another common cause of pancreatitis is alcohol, okay? And alcohol can obviously cause my elevated AST and ALT, especially in that 1.5 to 2 to 1 ratio. Like, so literature is saying 2 to 1 or 1.5 to 1. Remember, it's somewhere around that ratio. So don't just jump to it, right? Use all the clinical clues. Don't rush to that ERCP unless the obstruction persists or cholangitis develops. Always stabilize before we do any kind of procedural interventions. And then cholecystectomy before discharge prevents the reoccurrence. All right, cholangiocarcinoma. So we're going to see progressive jaundice, pruritus from the bile salt accumulation, pale stools and dark urine. We've talked about weight loss, anorexia, fatigue, right upper quadrant discomfort, often mild, not sharp or pain. And they may have hepatomegaly or they may have palpable gallbladder, which is called Cavorsier's sign. So again, that can happen with pancreatic cancer, or if we have cholangiocarcinoma kind of around this area, it'll lead to reflux of bile back into the gallbladder. It'll cause the gallbladder to be a little more distended. So we can feel that on exam. Um, so with this, what is the pathophysiology of cholangiocarcinoma? It's a malignant tumor of the biliary epithelium. It can arise intrahepatic. It can be perihilar, which is called a Klatskin tumor, or it can be in the distal CBD. The tumor obstructs the bile ducts. It leads to progressive cholestasis and then liver dysfunction. So my labs, my ALP is going to be elevated due to the bile duct inflammation. So is the GGT, same reason. The bilirubin is often elevated. The AST and ALT are also mildly elevated. We might see elevated tumor markers like CA19-9 and CEA, tell me some sort of like peritoneal process. And white blood cell count are typically normal unless this becomes complicated. Um, so again, next steps, we're going to do initial imaging like we always do, right upper quadrant ultrasound. If that's not showing us what we want to see, maybe we'll jump to a CT abdomen. The best tests for us are going to be an MRCP to look at the actual bile duct pathology themselves. And ERCP is both will be diagnostic because we can actually sample the tissue, right? And then look at it under a microscope. If we're able to, let's surgically resect it. We can do palliative stenting for advanced disease and then chemo and radiation. So major risk factors, remember, cholangiocarcinoma loves to run with PSC and PSC loves to run with UC. So in my head, I always put those together, cholangiocarcinoma, PSC, and UC. Liver flukes, like I can't even say like clonorhynchus and senescence, can also predispose to cholangiocarcinoma. There are things like colodocal cysts and chronic biliary inflammation can all predispose to cholangiocarcinoma, which again is a malignant tumor of the biliary epithelium. We can see progressive painless jaundice that distinguishes it from acute cholangitis because those patients are going to be severely ill and have systemic symptoms. A Klatskin tumor involves the biliary confluence, which is the perihilar region. And then Cavorsier's sign, we have a non-tender enlarged gallbladder with obstruction distal to the cystic duct, which I showed you previously. All right, two more diseases. PBC. So we're going to classically think about these in middle-aged women. It impacts females way more than males. We'll often see fatigue. We'll see pruritus, again, from the buildup in the bilirubin. And it's really like the bile acids themselves are going to cause a lot of that itchiness, right? So you'll see the patient has like intractable itching, but they don't have a rash, right? That's one sign. There's a couple things that can lead to that. Some things like Hodgkin's lymphoma. Some things like uremia can also cause that. Just off the top of my head. So it's one sign that might point me towards a bile acid or bile salt or bilirubin problem. We'll see right upper quadrant discomfort, jaundice late. It loves to run with other autoimmune diseases, especially Sjogren's. So you might see dry eyes and mouth. We might see autoimmune thyroid disease, rheumatoid arthritis, scleroderma. We could throw lupus in there too. Pathophys, it's autoimmune destructions of the intrahepatic small bile ducts. We get chronic bile stasis, cholestasis, and eventually it can even progress to cirrhosis because of all this hepatocellular inflammation and fibrosis. We get progressive loss of those bile ducts. And then again, like I said, fibrosis and liver failure. So what are we going to see? We're going to see really high ALP. We're going to see high GGT. The bilirubin may rise as the disease advances. The AST and ALT are usually elevated from this damage to the liver cells themselves. The anti-mitochondrial antibodies are classically positive, right? So if we ever suspect primary biliary cholangitis, we should always say on USMLE, I want to get an AMA. We should always say in real life, I want to get an AMA. The lipid panel may show elevated cholesterol, and skin findings may show then xanthomas, which tells me my lipids are depositing into the skin. And I'll talk about why on, I think I've got it on one of the next slides. So with regards, well, actually, I'll just explain it because I don't think I have it. with regards to this, right? Remember, bile acid and cholesterol are in it, they're linked together. So when I can't, like the cholesterol helps make up the backbone of the bile acids. So when I can't remove my bile acids, the lipids, the cholesterol builds up in the system. It's got nowhere to go. Okay, so that's usually why these patients will have elevated cholesterol. So again, what kind of keys me into a patient with PBC? It'll be like a 45-year-old woman. They've got fatigue, they've got pruritus, they've got right upper quadrant ultrasound or right upper quadrant discomfort. They might have some of these other autoimmune findings. They'll have elevated cholesterol and maybe potentially xanthomas. I'm thinking about PBC. Let me get an AMA. Let's do a right upper quadrant ultrasound. So again, yeah, here's where I talked about it. So fat malabsorption, hyperlipidemia, we can't excrete cholesterol as well. That kind of explains that. Diagnosis, so again, positive AMA and cholestatic labs. First line treatment is ursodeoxycholic acid, which helps us help the enterohepatic circulation of the bile acids to help remove some of these excess bile acids. We monitor for progression to cirrhosis and liver transplant if end stage. So USMLE tips again, middle-aged woman with fatigue, pruritus, elevated ALP, think about PBC. AMA positivity is basically how we diagnose. The ALP is often elevated way out of proportion to the AST and ALT, and we want to differentiate from PSC. There's no association with ulcerative colitis, and it's intrahepatic ducts only, and that is opposed to PSC, where we get intra and extrahepatic bile duct problems. So in PSC, this is classically young to middle-aged men. So PBC, more women, PSC, more men. It's often asymptomatic initially. We might see fatigue and pruritus. We might see progressive jaundice. They may have the recurrent cholangitis, so fever and right upper quadrant pain, and it's strongly linked with UC. I can't tell you how many times I've seen this question where the patient either has PSC and they ask you, what other disease might they have? Or something like that. Or the patient has UC and they ask it the other way. Like, what other disease might they have? PSC. Pathophys, we get chronic progressive inflammation and fibrosis of intrahepatic and extrahepatic bile ducts. We'll see this concentric onion skin fibrosis. They might call it like beading too. You'll see strictures. You'll get bile stasis. The bile stasis will reflux back and we can get hepatocellular damage. It can lead to cirrhosis. And this is also causing chronic damage to my bile duct epithelium, which is just asking for cholangiocarcinoma, because anytime my cells get damaged, they got to replenish, right? They got to recover. If we do that too often, it's just asking for a mutation to occur. So again, labs, ALP is often elevated, GGT is elevated, bilirubin is elevated as the disease progresses. AST and ALT are often elevated. PSC and UC love to run with P-onca positivity. Remember, it's non-specific. I can think about, I'll do a whole lecture on vasculitis. I love talking about the vasculitis, like the small vessel onca positive vasculitis. EGPA and MPA right off the top are also P-onca positive. So we can't just be like, oh, it's P-onca positive, it's got to be PSC, right? Other things can be P-onca positive. And the white blood cells may be elevated if we have cholangitis. So again, next step in management, we'll do our cholestatic labs and clinical suspicion. We're probably going to do the best test for PSC is by far MRCP. We could do ERCP2, which will show the beating, like I just talked about, and multifocal strictures and dilatations. There's really no curative medical treatment. So remember, in PBC, we could use ursodeoxycholic acid, which can stave off the disease, help the enterohepatic circulation. There's not much in PSC. It really sucks. We're going to monitor for complications like cirrhosis and cholangiocarcinoma, and then liver transplant if they need it. So tips for the exam, young man plus UC plus elevated ALP, think about PSC. The MRCP is my go-to. We'll see the classic beading and onion skinning fibrosis. Strong risk for cholangiocarcinoma. There's no role for ursodeoxycholic acid. It does not work. This is both intra and extrahepatic bile duct inflammation and fibrosis. And then always screen for IBD, especially ulcerative colitis, if PSC is diagnosed. All right. So this was my schema. I am not going to go through all this. I put this on here so you guys can take a screenshot and then use it on your own for studying. But again, we talked about biliary colic, acute cholecystitis, choledocholithiasis, ascending cholangitis, gallstone pancreatitis, PBC, PSC, cholangiocarcinoma. Please, please, please take a screenshot of this. If for some reason it's not showing up on your screen like perfectly, if it's blurry, email me and I will send you the slide, because this is literally everything I said in one fell swoop. Okay, I don't want to waste my time reading it, you guys can read this on your own. Okay, so let's put it all together. We have a 34-year-old woman presents with 3 days of abdominal pain, nausea, and dark urine. She has a history of recurrent headaches and transient confusion over the past month. Her physical exam reveals scleral icterus, mild right upper quadrant tenderness, and scattered petechiae on her lower extremities. Her neurological exam is non-focal. Her labs show a hemoglobin of 7.9, platelets of 22, reticulocyte count of 9, total bilirubin of 4.2, AST is 34, ALT 29, ALP 92, creatinine 1.8. The LDH is markedly elevated. The haptoglobin is undetectable. On peripheral smear, we see 3% of the population of cells are helmet cells. An abdominal ultrasound is performed and reveals gallstones, but no biliary duct dilation or wall thickening. Which of the following most accurately explains the patient's gallstone formation? So I threw a lot at you on this in this lecture and a lot at you in this case. So try to answer. So look at the pathophys I'm talking about on the bottom. Pause your screen. Think through what disease do you think this patient has, right? I picked a very specific disease I wanted to ask you about because I've talked about it before. What disease do you think she has? And then how does that explain the gallstone formation? So pause and think. All right, so this lady has TTP. So I talked about this in my MAHA lecture. If you haven't watched the MAHA lecture, go watch that. It's going to be the only lecture you're ever going to need on MAHA. I explain everything. In TTP, we have an autoimmune destruction of ADAM-TS13. ADAM-TS13 is the enzyme that breaks down or cleaves von Willebrand factor into smaller bits. In this case, von Willebrand factor stays large. It activates all my platelets. My platelets then form clots, okay? Classically up in the brain, classically in the kidney. This then leads to a massive thrombocytopenia. So my patient had a platelet count of 22, though, because we're using up all my platelets and they're forming clots. And now anytime my red blood cells shear across, they move across, they get sheared and we get hemolytic anemia. So we're going to have an elevated LDH, a low haptoglobin, and elevated indirect bilirubin. And I gave you all that here. LDH is elevated, the haptoglobin is low. The total bilirubin is elevated with a direct bilirubin that's only 0.8. So that means my indirect bilirubin is quite high. Okay. So when I have that, I also see helmet cells. Helmet cells are another name for schistocytes. So don't be thrown off by that. When my schistocytes make up greater than 1% of the diagnosis, I need to, or greater than the population, I need to consider some sort of microangiopathic hemolytic anemia. In this case, it's a thrombotic microangiopathy. I explain what that means in my MAHA lecture, so go watch that again. We see elevated creatinine, so we see kidney damage. We see low hemoglobin, low platelets, elevated reticulocyte count, which tells me my bone marrow is responding properly. And then we see the neurological manifestations where she has a confusion. This is more than enough for me to be a high clinical suspicion of TTP. We treat with plasma exchange first. Then we can do steroids, rituximab, and even caplacizumab, which is an anti-von Willebrand factor. I explain all that in the lecture. For this lecture, we got to figure out why is she having gallstones on top of this. Well, this patient is undergoing massive hemolytic anemia. So that's going to lead to a chronic elevation in bilirubin, which then will end up causing supersaturation, right? So the chronic hemolysis leads to increased production of unconjugated bilirubin, which is excreted in the bile. When that concentration of the unconjugated bilirubin exceeds the solubility, it precipitates as calcium bilirubinate and will form these black pigment stones. So again, we have talked about a lot of different types of gallstones and a lot of different pathologies. I wanted to ask you a case on hemolytic anemia because it's one that often gets forgotten. So again, we shear our red blood cells, we release increased amount of indirect bilirubin. Bilirubin is really like a backbone for bile to be produced, right? And so when I have increased bilirubin, it's going to saturate in that bile and it's going to classically lead to stones, right? So we need to think about it, right? I took this right from, or this line, like right from the American College of Gastroenterology. It notes that hemolysis is a key cause of indirect hyperbilirubinemia and pigment gallstone formation. So we need to think about chronic hemolytic states like TTP, sickle cell, hereditary spherocytosis. I've seen so many questions on hereditary spherocytosis causing this and sickle cell. I decided to switch things up and ask you about a different form of hemolytic anemia, especially considering I haven't done my formal hemolytic anemia talk, but I have done my talk on TTP, so I figured that would be safe. So again, hemolytic anemia, impaired hepatic bilirubin conjugation, I picked the wrong one. chronic bilirubin overproduction from intravascular hemolysis. So again, the intravascular hemolysis leading to indirect bilirubin. All right. If you want to read more, here are 2 articles I helped use as the backbone to making this lecture. Screenshot these, throw them into Google. Really good lectures on acute biliary disease and the cholangiopathies. Again, today we talked about so many different gallbladder pathologies. We covered all of them in less than an hour. I talked to you all about different, like how gallstones form. We talked all about cholestatic pattern of liver disease. So I'm really hoping this helped cleared up a lot of things. If you're still confused, here's my email. Do not be afraid to email me. I'm here to help you guys. Until next time.